Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the channel of Stand Medical lecture or notes. Let us discuss the last acute complication of diabetes in the context of last acute complication of type 2 diabetes mellitus, that is lactic acidosis. Lactic acidosis occurs in various conditions, but we will discuss here in the context of diabetes mellitus. Okay, let's begin with the name of Almighty. So, concept and definition. Lactic acidosis is a severe form of high anion gap metabolic acidosis characterized by a systemic accumulation of lactate more than 4 millimole per liter and profound acidemia, pH less than 7.3, okay, 7.35. So lactic acidosis means there should be three things. There should be a high anion gap, which is calculated by sodium plus potassium minus chloride and bicarbonate. So normally the anion gap is less than 12 actually. So it will be more than 12 in high anion gap acidosis. Okay. So there should be a high anion gap, number one. Okay. Number two, there should be a high lactate level, more than 4 millimole per liter. Number three, there should be acidosis, pH less than 7.3, actually you can say 7.35. Okay, three things: high anion gap, pH increased, lactate levels increased. While lactic acidosis can occur in any critically ill patient in the specific context of diabetes mellitus pharmacotherapy, the clinical focus heavily centers on Metformin-Associated Lactic Acidosis, short form it is also called as MALA. Okay, so this is common in diabetes mellitus patient, and that too particularly in elderly aged patients who are critically ill and with comorbidities like CKD or liver disease. So in these patients it is very much common. So what it is: accumulation of lactate in the blood leading to severe metabolic acidosis. Focus is on metformin associated lactic acidosis. MALA is an exceedingly rare but highly lethal. Historical mortality up to 30 to 50%. Half of the patients will die who develop this. It is an iatrogenic complication of biguanide therapy, that is nothing but metformin. What is the pathophysiology of lactic acidosis? First we will discuss. So lactic acidosis is classically bifurcated into two distinct pathophysiological mechanisms, both of which can converge in the diabetic patient. Type A lactic acidosis, which occurs due to hypoxia or hypoperfusion due to some cardiorespiratory condition. Type B lactic acidosis, which is metabolic or toxin mediated. Metabolic meaning due to some metabolic disorder like diabetes mellitus. Toxin mediated meaning because of some poisoning. Okay, so type A occurs because of hypoxia and hypoperfusion, whereas meaning due to some cardiorespiratory conditions, whereas type B occurs metabolic and toxin mediated. So this type A is driven by global tissue hypoxia, like in cardiogenic shock, severe sepsis, septic shock, okay, severe sepsis, severe anemia. Yes, tissue don't have oxygen, so they will go on for anaerobic metabolism. Massive hemorrhage. Okay, so lack of oxygen meaning hypoxia stalls the mitochondrial electron transport chain, forces the cells into anaerobic glycolysis. So anaerobic glycolysis, there pyruvate is converted to lactate. Okay, in this process NAD plus is generated, allows continued ATP production. So because the cells switch over from aerobic respiration, which occurs in mitochondria, to anaerobic respiration, anaerobic glycolysis, okay, the byproduct of that anaerobic glycolysis is lactate. That's why there is lactic acidosis in the conditions where the oxygen is low, like in hypoperfusion and hypoxia, or you can take it as severe sepsis, severe anemia, loss of blood, hemorrhage. All these things can have lactic acidosis. In type B lactic acidosis, there is absolute absence of systemic hypoxia. It is due to mainly drugs or toxins like metformin, liver disease, okay, malignancy, endocrine disorders, okay, and mitochondrial disorders, drugs and toxins, liver disease, malignancy. Why? Malignant cells are very much active than the normal cells. They require a high amount of glucose for their proliferation. So again, because our body will not give that much of oxygen, they will switch over to anaerobic glycolysis, and that will lead to lactic acidosis in malignancy. Endocrine disorders like thyrotoxicosis, where there is hyperthyroidism. So again, the metabolism of body will increase, the total metabolism of the body will increase. So again, the requirement of oxygen will also increase simultaneously. But because the cells will not get that much amount of the demand is increased but the supply remains the same, that's why the cells will switch over to anaerobic glycolysis here, and that will lead to lactic acidosis. In mitochondrial disorders, there is no aerobic respiration or abnormal aerobic respiration, that's why there will be lactic acidosis. Okay, so in all these 5 conditions you will see lactic acidosis. So type B type of lactic acidosis is the primary mechanism of metformin-associated lactic acidosis, that is nothing but MALA. So typically we will discuss here metformin-associated lactic acidosis. So what is the mechanism behind that? Metformin will enter the liver cells, hepatocytes, and it will inhibit the mitochondrial complex, lowers the intracellular ATP, and activates the AMP kinase, which is the primary mechanism of action of this metformin. Okay, lowers the intracellular ATP and activates the AMP kinase. By that, it will suppress the hepatic gluconeogenesis. That's how it lowers the fasting blood glucose. That is a therapeutic effect. But again, it will increases the glucose turnover in splanchnic blood circulation, that is the intestinal blood circulation. So increases the baseline enteric lactate production. So in the gut, lactate production is increased because the glucose turnover is increased in the intestine. Okay. Liver is the primary organ that clears lactate, so via gluconeogenesis and the Cori cycle. If you have remember your physiology Cori cycle, then you will understand this. So because liver is the primary organ, okay, so that's why if any problem in liver is there, then that can lead to MALA, meaning metformin-associated lactic acidosis. And if AKI, meaning acute kidney injury or dehydration occurs, then again metformin is cleared very slowly, or it will not be cleared totally. So metformin is not metabolized, exclusively cleared unchanged by the kidneys. Okay, so that will lead to metformin accumulation, massive inhibition of mitochondrial respiration, liver unable to clear the expanding lactate pool. Okay, liver unable to clear the expanding lactate pool, runaway accumulation of lactic acidosis. Okay, runaway accumulation of lactic acid, sorry. Okay, so metformin's actions create a physiological vulnerability, decreased gluconeogenesis with increased lactate production. When kidneys fail, metformin will accumulate and overwhelm the system, even in the normal liver also. For example, in critical illnesses, when there is dehydration or due to some reason there is acute kidney injury, what will happen? Because the metformin is not cleared by the kidneys, so metformin is accumulated. So this metformin actually is cleared by the liver. So but the mechanisms which are clearing this lactate are overwhelmed because of excessive metformin, that will lead to lactic acidosis. Okay, that's the mechanism of action. Okay, so what are the clinical features, key signs, and must not miss diagnosis? MALA lacks the highly specific clinical markers seen in diabetic ketoacidosis. There will be no fruity breath. Kussmaul's respiration only appear late when profound acidosis demands respiratory compensation. So typical clinical course of MALA is, first there will be a prodrome, insidious, generalized malaise, severe non-specific abdominal pain, severe, and nausea and vomiting. Okay. Then there will be worsening acidosis, which causes myocardial depression and vasoplegia, paralysis of vascular smooth muscle. That will lead to hemodynamic collapse, leads to severe refractory vasodilatory shock and hypothermia. Okay, so myocardial depression occurs because of acidosis, and there will be vasoplegia, paralysis of the the smooth muscles of the blood vessels. So because there is myocardial depression and vasodilation, that will lead to severe refractory vasodilatory shock and hypothermia because of excessive heat dissipation by the vasodilated blood vessels. And that will also lead to neurological decline, altered mental status, and coma follow rapidly as perfusion plummets. So as perfusion drops abruptly, there will be abnormality in the neurological decline in the patient. Okay, this is how the clinical course of MALA. So first there will be a prodrome of GI symptoms will be there: nausea, vomiting, severe non-specific abdominal pain, and generalized fatigue. So this will progress to reduced cardiac output, severe refractory cardiac shock, it will vasodilatory shock it will lead to, and that will progress to neurological dysfunction. So that is the course of MALA. Must not miss diagnosis and triggers. Number 1, occult sepsis, the double hit. Underlying infection, that is nothing but sepsis, along with dehydration will, so underlying infection will lead to dehydration. Dehydration will cause acute kidney injury. Acute kidney injury will lead to decreased metformin clearance, and that will precipitate Metformin-Associated Lactic Acidosis. This creates a devastating mixed type A and type B lactic acidosis picture, because sepsis itself creates lactic acid, and because the blood flow is reduced to the kidneys and metformin accumulates, that will produce again lactic acid by type B type of lactic acidosis. So mixed picture will be seen in case of severe sepsis. Number 2 is, so these are the triggers, actually the important trigger: sepsis and dehydration. In normal patients who have a normal kidneys and who have normal liver, there the most common reason is sepsis and dehydration. Because of reduced metformin clearance, MALA will occur. Okay, and in patients who are already on CKD and or liver disease, they are again very much prone for developing this MALA. Second trigger is iodinated contrast administration. So iodinated contrast administration will lead to contrast induced nephropathy that will cause rapid drop in renal clearance of metformin. So metformin dosing becomes a fatal toxic overdose, can rapidly obliterate renal clearance in vulnerable diabetics. This is also an important point. So for example, if patient is having coronary artery disease also, and he is undergoing angiography, they'll give contrast first. So that is there also, it should be kept in mind that the contrast causes nephropathy, and nephropathy can lead to metabolic MALA, Metformin-Associated Lactic Acidosis. So any condition which impairs the kidney function, that is the basic concept. Any condition which impairs the kidney function will lead to metformin accumulation, and that will overwhelm the mechanisms of lactate clearance in the liver, and that will cause Metformin-Associated Lactic Acidosis. What are the symptoms? There will be a prodrome first, then that will lead to acidosis, that will cause severe refractory vasodilatory shock and further neurological decline. So what are the differential diagnosis? So differential diagnosis is first diabetic ketoacidosis. So in diabetic ketoacidosis, there will be marked hyperglycemia, profound ketonemia. Okay, diabetic ketoacidosis features marked ketonemia. MALA presents with massive lactate elevation. So there will be no ketosis here in Metformin-Associated Lactic Acidosis. Ketosis is not there, but both cause high anion gap metabolic acidosis. Both will cause high anion gap metabolic acidosis, but there will be no ketosis, or sometimes there will be no hyperglycemia. But actually in severe intercurrent illnesses, there is a hyperglycemia actually. So we can't take that as a clinical differentiating marker. So we can take this ketosis. Okay, even the ketosis can also be there. So we can also have this type of mixed picture. The patient can have diabetic ketoacidosis also, and the patient can also have Metformin-Associated Lactic Acidosis also. We can have this type of picture also. So this is first differential, but this is typically seen in mainly seen in type 2 also seen, but mainly in type 1 it is seen. Second we should decrease is septic type A, primary type A type of lactic acidosis, mainly there is septic shock. So this requires extensive infectious disease workup to identify the source of hypoperfusion. Look for infection positive cultures, elevated inflammatory markers that will help to differentiate. So third is toxic ingestion. So salicylate toxicity, mainly like aspirin or NSAIDs toxicity, and toxic alcohols like methanol or ethanol glycol. These also already discussed in DKA also. We should differentiate from these things. So these are differentiated by osmolar gaps and specific serum assays. So in these toxic alcohol cases, there will be increased osmolar gap actually. So check the osmolar gap, anion gap, and order specific toxin levels. Salicylate toxicity and toxic alcohols. Okay. Fourth is mesenteric ischemia. Diabetics are at high risk for vascular disease. Ischemic bowel produces profound abdominal pain and massive lactate elevation out of proportion to physical examination findings. So abdominal pain along with, because of mesenteric ischemia, there will be enormous amount of lactic acid production. So that we need to differentiate. So it can be mesenteric ischemia also in type 2 diabetes mellitus. Okay, these are the four things we need to differentiate. Okay, then coming to diagnostic approach, how you will diagnose. Immediate diagnostic workup demands an arterial blood gas and rapid serum lactate. So one thing we should be kept in mind is anything which compromises kidney function can cause MALA, Metformin-Associated Lactic, and it can be associated with your HHS also, and it can be associated with DKA, because both DKA and HS are precipitated by intercurrent illness. So we need to differentiate between these three mainly, and also causes of type A lactic, any cardiorespiratory condition which cause hypoxia. So that also need to be differentiated. So that is possible only with ABG and lactate, serum lactate. So the diagnostic approach is ABG and lactate. So serum lactate more than 4 millimole. Okay, that is increased lactate level. Often exceeds 10 to 20 millimole per liter in severe MALA, metformin associated with MALA. So severe MALA is associated with more than 10 to 20 millimole per liter of serum lactate. There will be severe metabolic acidemia. pH commonly drops less than 7.1 in MALA presentation. Severely lactate elevation, severely decreased pH less than 7.1, and renal dysfunction. There will be elevated serum creatinine and BUN, confirms the underlying acute kidney injury driving the toxicity. Anion gap, corrected anion gap, sorry. So that is nothing but sodium minus, I said something wrong, sodium, no potassium, sodium minus chloride plus bicarbonate, okay, plus 2.5 into 4 minus albumin. That is the formula for corrected anion gap. Sodium minus chloride plus bicarbonate plus 2.5 into 4 minus albumin. 2.5 into 4 minus albumin. So anion gap will be increased, reveals a profound unmeasured anion accumulation. So additional supportive findings will be, there will be high anion gap, metabolic acidosis on ABG. There will be low bicarbonate, of course. Hyperlactatemia will be there, and evidence of hypoperfusion will be there. Hypotension will be there. Increased lactate will be there. So these are the findings. Okay. Okay. Management strategy of severe MALA. So we'll discuss about mild to moderate MALA, how to manage. Mild to moderate MALA is managed conservatively. Severe MALA requires aggressive critical care support. Remember this point, okay? So the management of severe MALA is highly complex and hinges on aggressive critical care support and rapid extracorporeal removal of both the drug and the accumulated toxin. So that needs extracorporeal removal of both the drug and the accumulated toxin. So first one is discontinuation of the offending agent, that is metformin. Immediately halt metformin and withhold any other nephrotoxic agents. Examples of nephrotoxic agents are NSAIDs, okay, which will impair the kidney function. IV contrast, again impair the kidney function. Aminoglycosides, again impair the kidney function. So discontinuing of the offending agent. Stop metformin and stop all those nephrotoxic agents which impair the kidney function. Second is hemodynamic resuscitation. Aggressive volume expansion with isotonic crystalloids. Vasopressor support norepinephrine first line to maintain a mean arterial pressure of more than or equal to 65 mmHg. Mechanical ventilation for airway protection and respiratory failure. Essential to this step is essential to contract acidosis induced vasoplegia and support organ perfusion. This step is important. Okay. Third one is renal replacement therapy. Definitive and life saving corner support of MALA treatment. Okay. So intermittent hemodialysis is first line and most effective. Rapidly clears metformin, which is small and water soluble drug, clears lactate and corrects acidosis via bicarbonate dialysate. Hemodialysis indication. Initiate hemodialysis if pH is less than 7 or less than 7.1, so meaning severe acidosis, or lactate is more than 20 millimole per liter, meaning severe acidosis. Refractory to supportive care. In case of mild to moderate MALA, if supportive care is if the patient is refractory to supportive care, then you can go on for HD hemodialysis. So the main condition, hemodialysis condition, is severe lactotemia and severe acidosis less than 7.1, and lactotemia more than 20 millimole per liter. That is hemodialysis. Continuous renal replacement therapy is an alternative if the patient is too hemodynamically unstable to tolerate the rapid fluid shifts of intermittent hemodialysis, though it clears metformin less efficiently. Fourth one is bicarbonate therapy. This is again highly controversial, which we have studied in DKA also. May temporarily correct serum pH, but does not fix the underlying mitochondrial blockade. Can increase intracellular carbon dioxide, worsening the intracellular acidosis. When to use then? It is generally reserved as a temporizing bridge to hemodialysis in patients with severe acidemia, pH less than 7.1, and profound hemodynamic instability. There it is used. Okay. So the ultimate goal is to remove metformin and lactate, correct the acidosis, support the hemodynamics, and treat the underlying condition, example sepsis, AKI, and dehydration. Key point is early recognition and prompt initiation of hemodialysis significantly improve survival in MALA. Important is management should occur in an intensive care setting with frequent reassessment of hemodynamics, acid-base status, electrolytes, and organ dysfunction. Now what I'm inferring from all these DKA, HHS, all these conditions is all the diabetes patients should be, who are in critical illness, should be well hydrated actually. Because if these patients are not well hydrated and their kidney function is not taken care of, then this DKA, HHS, and all this metformin MALA is going to take place. That means we should take care. Fluid therapy is very important in case of diabetes patients when they enter a critical when they go through a critical illness. Okay, that is I'm inferring from all these topics. Because if you don't give only a important fluid therapy, then patient will have all the three or maybe both, like DKA plus MALA or HHS plus MALA, they can have acidosis. So that is very important. Okay, so when to suspect MALA? MALA can be suspected when there is severe acidosis. Okay, MALA causes severe acidosis, and there will be shock. Patient will be having vasodilatory shock, and patient will be in hypothermia. Okay, and CNS decline will be present in both DK and HHS. Okay, severe acidosis, MALA should be suspected along with hemodynamic shock. Coming to special situations and pitfalls. Prescribing metformin renal failure. The most dangerous clinical pitfall in primary care is failing to monitor renal function. So remember this point. Metformin is absolutely contraindicated when the patient's eGFR is less than 30 ml per minute. Okay, use with extreme caution and dose reduction when the eGFR is 30 to 45. Nothing but you can take it as C3b. Okay, C3b stage, glomerular filtration, C3b. Okay. Monitor renal function regularly, at least every 3 to 6 months or more frequently in high risk patient. Adjust dose or stop metformin if renal function declines. So particular care should be taken in patients who are having G3b, G3b stage. Okay, G3B 30 to 45. Okay, that is the first one, very important. Number 2 is the perioperative and contrast pitfall. RSSDI and international guidelines mandate that metformin must be withheld prior to major surgery or the administration of iodinated IV contrast. That should be kept in mind before major surgery or before the administration of iodinated contrast. In both these things, metformin should be withheld. The risk of contrast-induced nephropathy or perioperative hypovolemia can trigger abrupt metformin bioaccumulation and MALA. Key takeaways: always assess renal function before starting metformin and in high risk situations. In two things, before starting metformin and in high risk situations. Withhold metformin during high risk procedures to prevent life threatening MALA. So anything which is going to affect kidney, like hypovolemia or some drugs which affect nephrotoxic drugs, are going to cause MALA. So on one side, MALA is a very good drug for diabetes mellitus. On the other side, these are the picture of MALA if the patient is having CKD. Okay. Metformin. So one case scenario, by seeing this case scenario, we will end this topic, and we'll be ending the whole this series of acute complications of type 2 diabetes mellitus. So now Metformin-Associated Lactic Acidosis, a practical case scenario. So MALA means, what is MALA? MALA means high anion gap metabolic acidosis plus lactate elevation in a patient taking metformin, usually precipitated by renal dysfunction, hypoxia, sepsis, dehydration or contrast exposure. So this is the definition of MALA that should be copy pasted in the mind. Copy and pasted in the mind. High anion gap metabolic acidosis with lactate elevation, but this can also occur in diabetic ketoacidosis. Okay, diabetic ketoacidosis, but not in HHS mainly in DKA it can occur. Okay, but when do you suspect patient is taking metformin and precipitated by renal dysfunction or hypoxia, also even sepsis also. Okay, hypoxia, sepsis and dehydration. So that means patient or some nephrotoxic agent. So what hypoxia? Again, this hypoxia, sepsis and dehydration will cause renal dysfunction only. They should be well dehydrated, and whenever there is critical condition, prompt antibiotic administration should be there when you suspect sepsis in this patient. And don't give nephrotoxic agents in this patient, because otherwise they will develop. That's why there is already we have discussed the sad man's protocol. The drugs which should be stopped in a patient who is a diabetes patient when he develops critical illness. So one is sulfonylureas. A for sulfonyl. So one is metformin. Okay, and N sulfonylureas. S for SGLT2 inhibitors. Okay, N for NSAIDs. Okay, and D for diuretics exacerbate. Okay, because these things what these things will do, these things are the trigger for MALA. That's why these guidelines are there. SADMANs, this is AC inhibitors, and this is ARVs. Again, all these things will affect the kidney only. They will affect. So to prevent MALA only, these guidelines are there. The SADMANs drug should be stopped for some time in critical illness in these patients. That should be kept in mind. Okay, very important. Okay, now coming to the management of mild to moderate MALA first. A 62-year-old man with type 2 diabetes mellitus on metformin 1 gram twice daily, meaning the maximum dose 2 gram, presents with 2 days of vomiting and poor oral intake. He feels weak and dizzy. Presents with 2 days of vomiting and poor oral intake, feels dizzy and weak. BP is 110/70, heart rate is 96, slight tachycardia, respiratory rate is 20, and SpO2 is 98%, respiratory slightly elevated. Labs include pH is 7.2, so acidosis is there because it is less than 7.3. Bicarbonate is also decreased, 16 milligram, it is less than 18. Okay, Lactate is 6.2, so elevated, more than 4, but not severe. And anion gap is 20, okay, more than 12, so increased anion gap. And see, this point will help you. Creatinine is 1.8 milligram per deciliter, baseline is 1. So diagnosis is mild to moderate MALA. There is no trigger here actually. The main thing which is giving clue here is this creatinine levels. Creatinine levels are giving clue. Okay. Lactate, mild to moderate, mild to moderate meaning the lactate levels are 4 to 10 millimeter and pH is less than 7.3, but the patient is hemodynamically stable. Okay, hemodynamically stable patient. Okay, he is having vomiting and poor intake. So these are the initial prodrome, no? This is the initial prodrome of these patients. Initial prodrome. Okay, that means pH and lactate levels are important. pH and lactate levels are important. Okay, and anion gap and bicarbonate, all these things. Now step by step management of these patients. Immediate action: stop metformin immediately, stop other nephrotoxic drugs. In one word I can say, stop the Sadman's regimen. One thing, stop the Sadman's drugs. Now assess ABCs, IV excess, monitor vitals. Treat the precipitating cause. Dehydration is the cause because the patient is having vomiting. Give IV fluids. Infection, if the cause is infection, start appropriate antibiotics. If the cause is heart failure or hypoxia, then correct that. So treat the precipitating cause, stop the Sadman's group of drugs and treat the precipitating cause. Then fluid resuscitation. Give 0.9% normal saline, 500 to 1000 ml bolus over 30 to 60 minutes. Then 150 ml per hour. Adjust based on BP, urine output and cardiac status. Now, so we have treated the cause. Dehydration we have treated. If it is infection, that we have treated. Cardiorespiratory cause, that also we have treated. Fluids we have given a lot of fluids. Okay. Now we are monitoring the patient. Oxygen should be kept above 94%. Maintain urine output more than 0.5 ml per kg, or we can say in a 60 kg man, urine output should be more than 30 ml per hour. 30 ml per hour. Okay. Treat the nausea and vomiting. Correct the electrolytes. This is also important. Correct the electrolytes. Okay. Reassess and repeat the test. Repeat ABG, lactate, creatinine every 4 to 6 hours. Track the trend. Lactate should decrease, pH should increase, bicarbonate should also increase, anion gap should decrease, creatinine should decrease. Look for clinical improvement. Now, what should be the titration and goals for mild to moderate MALA? Lactate should be less than 2.2. Okay, how to achieve that? Adequate perfusion, treat the cause and IV fluids. pH should be more than 3.5. How? Improve the perfusion, renal function and lactate clearance. Bicarbonate should be more than 22 milliequivalents per liter with improvement in lactic acidosis. Anion gap should be less than 12. Clear the unmeasured anions. That is nothing but lactate. Okay. Creatinine should be returning toward the baseline. Hydration, avoid nephrotoxin. Urine out should be more than 30 ml per hour. Give IV fluids and monitor. Okay. When to escalate, when to move towards severe pathway. Lactate is now more than 10. If it goes more than 10, or pH goes more than, you can say less than 7.1, worsening kidney function, or patient develops oliguria and hemodynamic instability, or you can say if the creatinine is increased in the patient. So acidosis is worsening. Okay, lactate is rising, lactate is more than 10, acidosis is worsening, kidney functioning worsening, hemodynamic patient is having hemodynamic instability, or the patient is having altered mental status, then consider early nephrology consult and possibly dialysis. Expected outcome or goal is having hemodynamic stability, lactate normalization less than 2.2, pH more than 7.3, bicarbonate more than 22 milliequivalents, improving renal function, resolution of symptoms, identify and correct cause to prevent reoccurrence. Okay, that's about mild to moderate MALA. Now coming to severe MALA, severe metabolic associated lactic acidosis. A 68-year-old woman with type 2 diabetes on metformin 1 gram twice daily presents with confusion, rapid breathing and abdominal pain. There is a history of fever and poor intake for 2 days. History of fever is there and patient is not taking from 2 days. The BP is fallen. See, BP is fallen. It is a red flag. 82 by 50. Heart rate is tachycardia 128 per minute. Respiratory rate is 30 per minute. Already there is compensatory hyperventilation, but the saturation is also dropping. See, 90% at room air. So labs pH is increased. Sorry, this is actually wrong. pH is less. Bicarbonate is 8 milliequivalents per liter. Lactate is 18.5, and anion gap is 28, more than 12, 28 it is. Creatinine is 3.6 milligram per deciliter. So diagnosis is severe MALA because lactate is more than 10, pH is less than, it is correct only 6.95, pH is less than 7.1, and patient is hemodynamically unstable. Lactate is more than 10, pH is less than 7.1, and there is associated organ dysfunction. What is that organ dysfunction? Patient is in shock. Okay. Step-by-step management. Airway production, intubate if needed, high flow oxygen or mechanical ventilation, cardiac monitor, large bore IV or central line. Stop offending agents. SAD construct should be stopped. SADMANS. These should be stopped. Aggressive hemodynamic support. 0.9% normal saline bolus at a rate of 20 to 30 ml per kg. 1 to 2 liter rapidly. If mean arterial pressure is less than 65, after fluids, start vasopressor. If MAP is less than 45. Okay. First line is norepinephrine. Titrate norepinephrine to achieve a MAP of more than 65 mmHg. How do you titrate norepinephrine? Start with 0.05 to 0.1 micrograms per kg per minute IV. Increase by 0.05 to 0.1 microgram per kg per minute every 3 to 5 minutes till the target of MAP of more than equal to 65 mmHg is achieved. If norepinephrine is inadequate, add vasopressin 0.03 units per minute, or you can add epinephrine at 0.02 to 0.1 micrograms per kg per minute. Okay, that's how we are giving hemodynamic support to the patient. Definitive therapy here is renal replacement therapy. Intermittent hemodialysis, first line. Indications are pH should be less than 7 or 7.1, lactate more than 20, hemodynamic instability or failure of standard therapy, impaired kidney function. So targets and effect, the targets are to remove metformin, remove the lactate, correct acidosis using bicarbonate dialysate, correct electrolytes and fluid balance. If hemodynamically unstable and cannot tolerate hemodialysis, so consider continuous renal replacement therapy, clears metformin less efficiently but better tolerated. Adjunct therapy, treat the underlying cause like sepsis, you give antibiotics, source control. Consider sodium bicarbonate, which is controversial but indicated as temporizing bridge if pH is less than 7.1 with instability. Dose is 50 to 100 milliequivalents IV over 10 to 15 minutes. Then infusion as 150 milliequivalents in 1 liter of 5% dextrose in water at 75 to 100 ml per hour. Avoid overcorrection, monitor pH and sodium levels. Monitor intensively ABG, lactate, electrolytes every 2 to 4 hours. Urine output hourly. Okay. Hemodynamics, vasopressor dose, ventilator parameters, titration and goals for severe MALA. So initial status 18.5. Our goal is less than 2.2. How to achieve? Hemodialysis, treat the cause, restore the perfusion. Initial status pH is 6.95, but our goal is more than 7.35. How to achieve? Hemodialysis, perfusion and bicarbonate bridge therapy. Bicarbonate is 8 milliequivalents per liter. Goal to achieve more than 22 milliequivalents. How to give? By giving bicarbonate dialysate. Mean arterial pressure is less than 65. How to achieve? More than or equal to 65 mg. Give fluids plus norepinephrine titration. And if norepinephrine is not enough, you can give vasopressin 0.03 or epinephrine at 0.02 to 1 microgram per kg per minute. Creatinine is 3.6. Goal should be improving HD plus hemodynamic support. Mental status is confused. Patient should be alert. That is the goal. Treat acidosis and underlying cause. Saturation is 90%. Saturation should increase 94%. Oxygen, ventilation and perfusion. So that's about the treatment of severe MALA and mild to moderate MALA both. So the difference between these two is we are focusing on cause and treating the precipitating cause and removing the aggravating factors in mild to moderate MALA. Whereas in severe MALA, hemodialysis is definitely needed, and we are aggressively correcting the hemodynamic instability in severe MALA. Okay. How to prevent MALA? Prevention of MALA. What are the key points? Here it is there. Assess renal function regularly. Avoid metformin when eGFR is less than 30 ml per minute. Okay. Withhold metformin before iodinated contrast. Stop 48 hours prior. Restart 48 hours after if renal function is stable. Withhold before major surgery. Restart when patient is stable and renal function is normal. Ensure adequate hydration. This is also very important. Patient education rules, sick day rules. I said no, Sadman's protocol. So patient should be encouraged to take more fluids during critical illness, and he should be said whenever there is a condition of loss of fluid from the body, he should be said to stop this Sadman's type of group of medications temporarily. Okay, the ultimate goal is early recognition, prompt treatment, remove metformin, correct lactic acidosis, restore perfusion, renal function, treat the underlying cause. Timely management can be life-saving. That's all about the acute complications of type 2 diabetes mellitus. Thank you.